In the past 30 years, a lot has changed for people with intellectual and developmental disabilities. Our definition of community has gone from not being an institution to being in the community to being of the community and belonging. Our definition of institution has changed. It used to be hundreds of people living together, and now is 7 or more. And for some, it doesn't matter how many people. It's about attitude and control that can happen when one person lives in a place. We've moved away from the medical model and embraced a social model of disability. If this pandemic has taught us anything, perhaps we went too far away from the medical model. We need an integrated model that embraces human rights and social justice for people with intellectual and developmental disabilities. It's clear that people with IDD have better lives in the community. So what has made all this change possible over the past 30 years? It's direct support professionals. We have 4.5 million direct care workers in the United States, supporting aging adults and people with disabilities. Of these, about 1.3 million are direct support professionals, supporting people with intellectual and developmental disabilities. But did work life get better for DSPs in the past 30 years? No. The unfortunate truth is that when we built the community system, we said that we would provide the service for less money, about 30% less. That savings came right out of the budget line items for wages and benefits paid to direct support staff. We have never caught up. Direct support professionals work as interdisciplinary professionals in community settings. They may work independently in various settings, and their jobs are skilled and hard, and they make ethical decisions and problem solve all the time. Our descriptive language too often speaks about these individuals as being entry-level and low-wage workers or caregivers, but that narrative must change. DSPs do many things in the states that even licensed nurse practitioners are not allowed to do. We need to focus on the complex skills these employees need and evolve to be good at what they do. The work of DSPs goes well beyond the direct care worker. Their job is complex and multidisciplinary with duties that include being a teacher, a nurse, a counselor, a dietitian, psychologist, physical therapist, occupational therapist, chauffeur, personal trainer, and more. And unlike home health aides, personal care attendants, and certified nursing assistants, DSPs are not recognized by the Bureau of Labor Statistics with the standard occupational classification. The complex and nuanced work of DSPs is not officially recognized as a profession. In the past, services for people with intellectual and developmental disabilities were limited to segregated settings and institutions. Today, most people live in their communities, and their ability to thrive is due in large part to the work of direct support professionals. The broader field of direct care is among the fastest growing occupations in the United States. This is due to a number of factors: longer life expectancy, population growth, aging family caregivers, and the expansion of home and community-based services with a preference for less isolated settings. But increasing demand for services has not affected the supply of people working in direct support. Medicaid provides the primary funding for home and community-based services, and pay for DSPs has not kept pace with the rest of the economy. We are in a workforce crisis and have been for decades. So who are direct support professionals? 87% of the direct care workforce are women aged 25 to 64, and the median age of workers is 47. 50% of the workforce rely on public assistance. 60% are people of color. Immigrants make up as much as 28% of this workforce. Of the direct support workforce, 70% work full-time and 30% work part-time. For decades, annual turnover has been close to 50%, with about 35% leaving within the first 6 months. So why do DSPs leave? The reasons are many: inadequate pay and benefits, the stress of the work, lack of advancement opportunities, lack of supervision, and insufficient training. And turnover is expensive, and each job vacancy costs agencies between $4,000 and $5,000. Turnover and vacancy are especially difficult on the people receiving supports. Consequences include increased rates of harm and critical incidents and behaviors, longer waiting lists, and increasingly a return to segregated and institutional care. With the COVID-19 pandemic, conditions became worse. In 2021, most service providers were turning away new referrals, particularly those with higher staffing needs. 34% of providers discontinued programs and services, and waiting lists grew longer. Providers are struggling to achieve quality standards, and people have limited choice of who they live with and where. In 2021, the average provider spent an additional $900,000 to fill vacancies and train new staff. The challenges faced by the DSP workforce worsened as well. Staff shortages increased, people's routines were disrupted during lockdowns, staff and the people they served confronted new hygiene protocols, DSPs were deployed to unfamiliar settings, and personal protective equipment was in short supply. Many DSPs left their jobs to care for children out of school and family members. Many DSPs are working longer shifts during the pandemic, and disproportionately so for Black and African American DSPs. For 54% of DSPs, work-life balance was reported as worse or much worse than before the pandemic. Physical and emotional burnout and anxiety were among the most highly reported results of the pandemic on DSPs. The mental health of DSPs decreased across multiple factors, including anxiety, depression, and sleep difficulties. DSPs were and continue to be exposed to traumatic experiences, and exposure to a greater number of traumatized clients is significantly correlated with symptoms of secondary traumatic stress. Racial identity is also correlated. Attracting and retaining skilled DSPs poses an ongoing challenge to service provider agencies and the country. At the same time, challenges faced by the workers themselves are increasing as more and more people with complex disabilities live and work in communities and neighborhoods of their choosing. These people are also from diverse backgrounds that may not be similar to the racial, ethnic, linguistic, and cultural backgrounds of the staff that support them. This makes implementing strategies for recruiting and training DSPs even more critical. We've reported on the status of the DSP workforce many times and provided suggestions and strategies to stabilize and advance this workforce. Competencies that are built into the workforce strategies can improve workforce recruitment and retention. This workforce must have the knowledge, skills, and ethical compass to perform a wide variety of tasks to support people with IDD to be healthy, safe, valued, and engaged members of their communities. As we mentioned before, DSPs are interdisciplinary professionals. There are many competency sets, including the Centers for Medicaid and Medicare Services Direct Service Worker Core Competency Set, which was most recently revised in 2019. These can be used in a number of efforts, including marketing and recruitment for public service announcements and targeted marketing. In terms of selection and hiring, they can be used for competency-based job descriptions, structured observation and shadowing, realistic job previews. In terms of training and professional development, they can be used for competency-based training, where the knowledge, skills, and attitudes specific to the direct support professional workforce are embedded in professional development opportunities. We know that completion of online training and mentoring can decrease turnover, and people with disabilities experience improvements in employment, social relationships, inclusion, and safety when these are in place. States can build training-related costs into the reimbursement rates under their state Medicaid plan, and there are a number of competency-based training platforms available to this workforce, including the College of Direct Support, the College of Frontline Supervision and Management through the Direct Course Suite through Elsevier. We also know that DSPs need training and professional development. Credentialing can improve the skills of workers and create career paths that will help retain them. A job analysis of role and the demonstration of skill on the job can create career pathways, and those can be recognized by the National Alliance for Direct Support Professionals career path from the foundation level all the way to the advanced professional level direct support professional. We also know that we need to include supervisors and managers to engage, support, and retain the workforce, and they may not have the support that they currently need. Engagement and retention efforts are also important. Recognition programs like the Moving Mountains Award recognizes organizations that use these best practices to recruit, retain, and professionally develop DSPs. We also know that DSPs benefit from coaching and mentoring and networking in professional organizations like the National Alliance for Direct Support Professionals. We also know that we need to professionalize the direct support professional role, and the Bureau of Labor Statistics does not have a specific occupational category for DSPs. Given this, we asked, what do we need to know to better support direct support professionals and people with intellectual and developmental disabilities receiving supports from diverse racial, ethnic, linguistic, and cultural backgrounds? How do we best engage them in our research? Research questions and recommendations from this strand include, how is community living, which is a service construct, versus life, which focuses on interdependence and social capital and asks, how do you want to live, experienced by people with intellectual and developmental disabilities from diverse backgrounds? What are the implications of that on the validated DSP competencies? What is known about how to best engage DSPs in research outside of the gatekeeping organizations and state developmental disability agencies early in the research process and in the quantitative studies? We need to gather information directly from DSPs themselves to pay attention to sampling and get a representative sample that reflects the diversity of this workforce. What differentiates a healthy workforce culture? What are the attributes? What are the outcome differences for direct support professionals? What supports wellness and positive mental health? What discrepancies exist between the DSP perspective and the organizational perspective on organizational culture? What are the drivers and pressures of the home and community-based services system? What does the system need to do to better support the diversity of the workforce? Given the workforce shortage, how do we best support families from diverse backgrounds and cultures who may be self-directing? And how do we increase informed choice on support options? What kinds of new models can be developed that are reflective of what people and families of diverse backgrounds prefer? There are positive factors and drawbacks to working with individuals and families in their own home and in self-direction. How do we best support diverse DSPs? What are the rights and responsibilities of the family and the individual to engage in respectful treatment of the DSP to reduce trauma? What strategies are good at mediating that experience? Given all that we've known for decades and all that we learned during the pandemic, attending to the needs of direct support professionals and people receiving supports from diverse backgrounds now is critical for the vision of community living to be fully realized.